to a CDP and let go. Greater than 4.5 seconds is normal. Now we're on to peristaltic break, and we can actually measure peristaltic break on this one. Peristaltic break measures the break in the 20 millimeter isocontour line. And at the bottom of the striated muscle section to the top of the blue line, or the 20 millimeter isocontour line, at the top of the smooth muscle segment. So I just measure from here down to here, and a break of less than 2 centimeters is normal. So a normal contraction would have intact pressures or a small break. We can go ahead. If you want to mute your phone, once again, a reminder, you can press *6. And then if you'd like to unmute to ask a question, you can press *7. We measured the peristaltic break. I will just finish up with an IRP, and then we'll take a look at how these ended up on the report. I would measure the area of the LESP, or the LES relaxation area, and then get a live gastric baseline underneath. Less than 15 is a full relaxation, and log it. I'm ready to move on to the report, so I'm going to press Save. Does anybody have questions on the creation of those measurements?
So we don't have to label the swallows anymore?
Label them. They are already labeled when you create them in acquisition, so you still create them the same way as you always did.
Because remember you had taught us with each swallow you would go into log and type out.
Right. You do not have to. Right. She's talking about labeling each swallow and numbering them. That is correct. You do not have to label them separately. The computer will count them based on your LS event line.
Okay.
So you don't have to label them.
Okay. Thank you.
Good question. Thank you. I'm ready to move on to the report. But if I go ahead and move into the report, if you have further questions about the measurements, that's fine. We'll go back and discuss them. You go into Report, Create Report, and it says, well, I haven't analyzed. That's because I haven't analyzed anything traditionally. If you want traditional measurements, you would go ahead and edit those as well. And there are a few measurements that I'd like to mention that do not get calculated with the Chicago calculations. You have to look at those traditionally to have them on your report, and those would include your LES resting pressure, your LESP, your impedance data, liquid and viscous impedance, your profiling, your PIP proximal and distal, and then any UES or upper body data that you'd like. Those all have to be measured traditionally, but as far as your lower body contraction data and your LES data, that can all be taken care of with the Chicago. You would go into Report and Create Report, and then you would click on Options first time, go into Lower Esophageal Body, and make sure that your Chicago calculation table is checked on. Once you've done that, you won't need to do that in the future. You'll simply come into Report, Create Report, and it's coming up with some thumbnails. That message won't be coming up for you, so I'm not going to go over it. Go ahead and go right into the report, and I'll show you what a nice table this creates. You have your profiling data, your LESP data. Those were all obtained traditionally. If you did not do a traditional review of your relaxations, then you can just highlight the data and delete it. The computer tries to come up with numbers, but if you haven't reviewed them, it's best not to report them. If you did not review your swallows, you'll want to take that data off as well, and your data table off as well. Here is your Chicago calculation table. We have 3 swallows that we measured, and I had skipped over one, so it didn't include number 3. I didn't measure number 3. We did not measure a DCI on swallow number 1, or at least I didn't log it. I only logged the CFV on swallow number 1. Swallow number 2, we logged everything except for the distal latency. And swallow number 4, I'm not sure where our peristaltic break is. That should show up on there as well. And then it has an average down below for you. All these numbers are rounded, even though they originally gave it to you with a decimal. They are rounded to a whole number, except for your distal latency. Since the cutoff for normal distal latency is 4.5 centimeters, it does give you a decimal point. Shows up as a pretty nice little table. And then here's your viscous bolus transit data. I did. Any questions about that on the report or the creation of the measurements themselves?
I have a couple questions.
Yes, please, go ahead.
Do you do the Chicago calculations before the other if you know you're going to be doing them, or does it matter which sequence you go in?
It makes no difference which sequence you edit in. Just be careful that you do your temperature compensation first, and then you can either do traditional or you can do Chicago.
Okay. And
in any order.
And can you just review what the benefits of doing the Chicago calculations are, why you would do them? There's some people that I'm working with that are new to all of this. And
certainly. The traditional measurements review only a few select channels, really a lot like we used to use with our old esophageal and EFT probes. We were only analyzing 4 channels in the esophageal body and 1 channel in the LES. That's very limited data compared to what this probe is capable of giving us. And so the Chicago classifications really use the full capability of this probe, not just looking at a few points and getting amplitude and duration values, but getting volume and vigor data, really a much richer data over all the sensors in the esophageal body, not just the sensors 5, 10, 15, and 19 centimeters up. Does that help answer your question?
well, you wouldn't have to do this on every patient you do, though, correct?
The choice is yours in your practice, what you'd like to do. There are some practices that do traditional editing when a certain physician is reading the study because that's what he's comfortable with. They'll do Chicago measurements when another physician's reading, or they may just have gone completely to Chicago in their facility